everyone. Today, we will recognize and try to explain depression, which is one of the big problems of our society. Please do not forget to follow my YouTube channel. I'll start live video very soon.
What does depression mean, in short?
Depression is a mood disorder that causes a persistent feeling of sadness and loss of interest. Also called major depressive disorder or clinical depression, it affects how you feel, think and behave and can lead to a variety of emotional and physical problems. How do psychologists and psychiatric communities define depression?
First questions. What is depression?
Depression is a common and serious medical illness that negatively affects how you feel, the way you think and how you act. Fortunately, it is also treatable. Depression causes feelings of sadness and/or a loss of interest in activities you once enjoyed. It can lead to a variety of emotional and physical problems and can decrease your ability to function at work and at home. Depression symptoms can vary from mild to severe and can include feeling sad or having a depressed mood, loss of interest or pleasure in activities once enjoyed, changes in appetite, weight loss or gain unrelated to dieting, trouble sleeping or sleeping too much, loss of energy or increased fatigue, increase in purposeless physical activity, e.g., inability to sit still, pacing, hand-wringing, or slowed movements or speech. These actions must be severe enough to be observable by others. Feeling worthless or guilty, difficulty thinking, concentrating or making decisions, thoughts of death or suicide. Symptoms must last at least 2 weeks and must represent a change in your previous level of functioning for a diagnosis of depression. Also, medical conditions, e.g., thyroid problems, a brain tumor or vitamin deficiency, can mimic symptoms of depression, so it is important to rule out general medical causes. Depression affects an estimated 1 in 15 adults, 6.7%, in any given year. And 1 in 6 people, 16.6%, will experience depression at some time in their life. Depression can occur at any time, but on average, first appears during the late teens to mid-20s. Women are more likely than men to experience depression. Some studies show that 1/3 of women will experience a major depressive episode in their lifetime. There is a high degree of heritability, approximately 40%, when first-degree relatives, parents, children, siblings, have depression.
Depression is different from sadness or grief, bereavement.
The death of a loved one, loss of a job or the ending of a relationship are difficult experiences for a person to endure. It is normal for feelings of sadness or grief to develop in response to such situations. Those experiencing loss often might describe themselves as being depressed. But being sad is not the same as having depression. The grieving process is natural and unique to each individual and shares some of the same features of depression. Both grief and depression may involve intense sadness and withdrawal from usual activities. They are also different in important ways. In grief, painful feelings come in waves, often intermixed with positive memories of the deceased. In major depression, mood and/or interest, pleasure, are decreased for most of 2 weeks. In grief, self-esteem is usually maintained. In major depression, feelings of worthlessness and self-loathing are common. In grief, thoughts of death may surface when thinking of or fantasizing about joining the deceased loved one. In major depression, thoughts are focused on ending one's life due to feeling worthless or undeserving of living or being unable to cope with the pain of depression. Grief and depression can coexist for some people. The death of a loved one, losing a job or being a victim of a physical assault or a major disaster can lead to depression. When grief and depression co-occur, the grief is more severe and lasts longer than grief without depression. Distinguishing between grief and depression is important and can assist people in getting the help, support or treatment they need.
Risk factors for depression.
Depression can affect anyone, even a person who appears to live in relatively ideal circumstances. Several factors can play a role in depression. Biochemistry. Differences in certain chemicals in the brain may contribute to symptoms of depression. Genetics. Depression can run in families. For example, if one identical twin has depression, the other has a 70% chance of having the illness sometime in life. Personality. People with low self-esteem, who are easily overwhelmed by stress, or who are generally pessimistic appear to be more likely to experience depression. Environmental factors. Continuous exposure to violence, neglect, abuse or poverty may make some people more vulnerable to depression.
How is depression treated?
Depression is among the most treatable of mental disorders. Between 80% and 90% of people with depression eventually respond well to treatment. Almost all patients gain some relief from their symptoms. Before a diagnosis or treatment, a health professional should conduct a thorough diagnostic evaluation, including an interview and a physical examination. In some cases, a blood test might be done to make sure the depression is not due to a medical condition like a thyroid problem or a vitamin deficiency. Reversing the medical cause would alleviate the depression-like symptoms. The evaluation will identify specific symptoms and explore medical and family histories as well as cultural and environmental factors with the goal of arriving at a diagnosis and planning a course of action. Medication. Brain chemistry may contribute to an individual's depression and may factor into their treatment. For this reason, antidepressants might be prescribed to help modify one's brain chemistry. These medications are not sedatives, uppers, or tranquilizers. They are not habit-forming. Generally, antidepressant medications have no stimulating effect on people not experiencing depression. Antidepressants may produce some improvement within the first week or two of use, yet full benefits may not be seen for 2 to 3 months. If a patient feels little or no improvement after several weeks, his or her psychiatrist can alter the dose of the medication or add or substitute another antidepressant. In some situations, other psychotropic medications may be helpful. It is important to let your doctor know if a medication does not work or if you experience side effects. Psychiatrists usually recommend that patients continue to take medication for 6 or more months after the symptoms have improved. Longer-term maintenance treatment may be suggested to decrease the risk of future episodes for certain people at high risk. Psychotherapy. Psychotherapy, or talk therapy, is sometimes used alone for treatment of mild depression. For moderate to severe depression, psychotherapy is often used along with antidepressant medications. Cognitive behavioral therapy (CBT) has been found to be effective in treating depression. CBT is a form of therapy focused on the problem solving in the present. CBT helps a person to recognize distorted, negative thinking with the goal of changing thoughts and behaviors to respond to challenges in a more positive manner. Psychotherapy may involve only the individual, but it can include others. For example, family or couples therapy can help address issues within these close relationships. Group therapy brings people with similar illnesses together in a supportive environment, and can assist the participant to learn how others cope in similar situations. Depending on the severity of the depression, treatment can take a few weeks or much longer. In many cases, significant improvement can be made in 10 to 15 sessions. Electroconvulsive therapy (ECT) is a medical treatment that has been most commonly reserved for patients with severe major depression who have not responded to other treatments. It involves a brief electrical stimulation of the brain while the patient is under anesthesia. A patient typically receives ECT 2 to 3 times a week for a total of 6 to 12 treatments. It is usually managed by a team of trained medical professionals including a psychiatrist, an anesthesiologist and a nurse or physician assistant. ECT has been used since the 1940s, and many years of research have led to major improvements and the recognition of its effectiveness as a mainstream rather than a last resort treatment.
Self-help and coping.
There are a number of things people can do to help reduce the symptoms of depression. For many people, regular exercise helps create positive feeling and improves mood. Getting enough quality sleep on a regular basis, eating a healthy diet and avoiding alcohol, a depressant, can also help reduce symptoms of depression. Depression is a real illness and help is available. With proper diagnosis and treatment, the vast majority of people with depression will overcome it. If you are experiencing symptoms of depression, a first step is to see your family physician or psychiatrist. Talk about your concerns and request a thorough evaluation. This is a start to addressing your mental health needs.
Related conditions.
Peripartum depression, previously postpartum depression. Seasonal depression, also called seasonal affective disorder. Bipolar disorders. Persistent depressive disorder, previously dysthymia, description below. Premenstrual dysphoric disorder, description below. Disruptive mood dysregulation disorder, description below.
Premenstrual dysphoric disorder.
Premenstrual dysphoric disorder (PMDD) was added to the Diagnostic and Statistical Manual of Mental Disorders (DSM-5) in 2013. A woman with PMDD has severe symptoms of depression, irritability, and tension about a week before menstruation begins. Common symptoms include mood swings, irritability or anger, depressed mood, and marked anxiety or tension. Other symptoms may include decreased interest in usual activities, difficulty concentrating, lack of energy or easy fatigue, changes in appetite with specific food cravings, trouble sleeping or sleeping too much, or a sense of being overwhelmed or out of control. Physical symptoms may include breast tenderness or swelling, joint or muscle pain, a sensation of bloating, or weight gain. These symptoms begin a week to 10 days before the start of menstruation and improve or stop around the onset of menses. The symptoms lead to significant distress and problems with regular functioning or social interactions. For a diagnosis of PMDD, symptoms must have occurred in most of the menstrual cycles during the past year and must have an adverse effect on work or social functioning. Premenstrual dysphoric disorder is estimated to affect between 1.8% to 5.8% of menstruating women every year. PMDD can be treated with antidepressants, birth control pills, or nutritional supplements. Diet and lifestyle changes, such as reducing caffeine and alcohol, getting enough sleep and exercise, and practicing relaxations techniques, can help. Premenstrual syndrome (PMS) is similar to PMDD in that symptoms occur 7 to 10 days before a woman's period begins. However, PMS involves fewer and less severe symptoms than PMDD.
Disruptive mood dysregulation disorder.
Disruptive mood dysregulation disorder is a condition that occurs in children and youth ages 6 to 18. It involves a chronic and severe irritability resulting in severe and frequent temper outbursts. The temper outbursts can be verbal or can involve behavior such as physical aggression toward people or property. These outbursts are significantly out of proportion to the situation and are not consistent with the child's developmental age. They must occur frequently, 3 or more times per week on average, and typically in response to frustration. In between the outbursts, the child's mood is persistently irritable or angry most of the day, nearly every day. This mood is noticeable by others, such as parents, teachers, and peers. In order for a diagnosis of disruptive mood dysregulation disorder to be made, symptoms must be present for at least 1 year in at least 2 settings, such as at home, at school, with peers, and the condition must begin before age 10. Disruptive mood dysregulation disorder is much more common in males than females. It may occur along with other disorders, including major depressive, attention deficit, hyperactivity, anxiety, and conduct disorders. Disruptive mood dysregulation disorder can have a significant impact on the child's ability to function and a significant impact on the family. Chronic, severe irritability and temper outbursts can disrupt family life, make it difficult for the child, youth to make or keep friendships, and cause difficulties at school. Treatment typically involves psychotherapy, cognitive behavior therapy, and/or medications.
Persistent depressive disorder.
A person with persistent depressive disorder, previously referred to as dysthymic disorder, has a depressed mood for most of the day, for more days than not, for at least 2 years. In children and adolescents, the mood can be irritable or depressed, and must continue for at least 1 year. In addition to depressed mood, symptoms include poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, feelings of hopelessness. Persistent depressive disorder often begins in childhood, adolescence, or early adulthood and affects an estimated 0.5% of adults in the United States every year. Individuals with persistent depressive disorder often describe their mood as sad or down in the dumps. Because these symptoms have become a part of the individual's day-to-day experience, they may not seek help, just assuming that "I've always been this way." The symptoms cause significant distress or difficulty in work, social activities, or other important areas of functioning. While the impact of persistent depressive disorder on work, relationships and daily life can vary widely, its effects can be as great as or greater than those of major depressive disorder. A major depressive episode may precede the onset of persistent depressive disorder but may also arise during, and be superimposed on, a previous diagnosis of persistent depressive disorder. Now I'd like to share a presentation I made to you. I hope you like it.
Depression. Depression video parts. General information. Clinical pattern. Etiology. Current and forecast. Diagnosis of depression. Treatment. And conclusion. The main signs of depression have been known since the time of Hippocrates. At that time, the humoral theory of depression prevailed, and it surprisingly resonates with modern ideas about neuroendocrine and mediator disorders in affective disorders. Depression and anxiety disorders are among the most common mental illnesses in adults. Often depressive attacks occur suddenly, against the background of complete well-being. In other cases, they are provoked by psychotraumatic events, but then the symptoms develop independently of external influences. Depression is not just a pronounced form of unhappiness or despair. It should also not be confused with the natural loss response. The mortality, complication rate, and disability in depression are almost the same as in cardiovascular disease, and therefore its diagnosis and treatment are extremely important. Clinical pattern. Main symptoms of depression. Complete lack of vital interests. Feelings of satisfaction and pleasure from anything. Impaired appetite and sleep, loss of strength, decreased concentration and sexual desire. Feelings of inferiority and guilt, repeated thoughts of death or suicide. Usually there is psychomotor agitation or inhibition. For the diagnosis of a depressive attack in DSM-IV, a major depressive episode, the duration of symptoms should be at least 2 weeks. With particularly severe depression, sometimes called melancholy, objective symptoms are especially pronounced: weight loss, early morning awakenings, etc. Atypical forms of depression are possible. Some patients, most often teenagers and the elderly, do not express complaints and even deny that they have a depressed mood. Instead, depression can manifest itself as behavioral disorders, in particular, asocial behavior in adolescence or multiple vague somatic complaints. Often there are attacks of crying or constant tearfulness. Sometimes, on the contrary, patients cannot cry despite the feeling of despair and longing. Appetite is usually reduced, but it is possible, especially in the presence of atypical signs, on the contrary, an increase in appetite and weight gain. Sleep disorders also vary. A typical symptom is early morning awakenings, but some, on the contrary, sleep longer at night, hypersomnia, and experience drowsiness during the day. Dysthymia is a chronic disorder characterized by depressed mood or irritability in children, most of the time for at least 2 years, in children and adolescents 1 year. During periods of depressed mood, there may be a decrease or increase in appetite, insomnia or hypersomnia, loss of strength and fatigue, a sense of inferiority, impaired concentration, indecision, and a sense of hopelessness. Unlike depression, dysthymia usually leads to only minor or moderate social maladjustment, but due to its chronic course, it predisposes to the abuse of psychotropic drugs and alcohol, possibly in connection with attempts to get rid of a bad mood. Objective manifestations are also less pronounced than in depression. Significant emaciation or psychomotor retardation or agitation are rarely observed. Suicidal intentions and psychotic symptoms are atypical for uncomplicated dysthymia, but can be observed with the development of a depressive attack, double depression, on its background. Dysthymia is divided into on the primary, not caused by chronic non-affective disorders, and secondary, as well as on early and late. Early dysthymia begins before the age of 21. Perhaps early primary dysthymia is a separate disease. Prevalence. The prevalence of manic depressive psychosis in men and women is approximately the same, and monopolar depression, according to most studies, is observed in women almost twice as often. In the world, monopolar depression occurs in 4.7 to 25.8% of women and 2.1 to 12.3% of men. An extensive cooperative study of the ECA Epidemiological Catchment Area Statistics of the Centers for Public Health Services, conducted in the United States, showed that the probability of developing at least one depressive attack during life, according to the DSM-3 criteria, is 4.9 to 8.7% in women and 2.3 to 4.4% in men. Most international studies suggest that these differences are not an artifact related to sexual differences in attitudes to their health and treatment, but are due to biological and ontogenetic differences between men and women. Etiology theories. First one, psychosocial theories. Depression, especially in women, can be triggered by various psychosocial factors. These include lack of close relationships, family quarrels or divorce, lack of activities outside the home, loss of a mother before the age of 11, having more than 3 children in the family before the age of 14, recent death or illness of loved ones. The symptoms of depression can be influenced by ethnic and cultural factors. For example, American blacks develop hallucinations and delusions more often than whites of the same socioeconomic group. Second one, biological theories. Over the past 30 years, the biochemical and neuroendocrine mechanisms of depression have been intensively studied. However, there is no single biological theory that covers all the experimental data. It is shown that both manic depressive psychosis and monopolar depression have a hereditary component. Most twin studies have found independent inheritance of these diseases. For example, if one of the identical twins suffers from monopolar depression, then when the other twin develops depression, it is usually also monopolar. However, in some couples, both monopolar depression and MDR are observed, which may indicate a general genetic predisposition to these diseases. Genetic and chromosomal studies have not revealed a monogenic predisposition to monopolar depression. Perhaps it represents a whole group of diseases. Among relatives of patients with monopolar depression, the prevalence of this disease is 11 to 18%, which is 3 times more than in the general population. The mechanism of depression. Currently, the most well-founded serotonergic concept of depression. Many studies have shown a link between reduced activity of serotonergic systems and monopolar depression. It is possible that the effects of antidepressants are partly due to the desensitization of 5-HT2 receptors. There is also little evidence that some patients with depression have an increased sensitivity of presynaptic alpha-2 adrenergic receptors that inhibit the release of norepinephrine. This may lead to insufficient release of this mediator. A certain role may be played by increased activity of cholinergic systems. It is known that an overdose of M-cholinergic blockers leads, on the contrary, to euphoria. Current and forecast. Duration of the attack. In about 60% of cases, the attack ends in 6 months. Of the remaining patients, approximately 30% go into remission within the next 6 months. In 15% of those who have an attack lasting more than a year, it ends within the next 6 months. Finally, if the attack lasts more than 18 months, only 10% of cases go into remission within the next 6 months. Thus, the longer the symptoms of depression persist during treatment, the lower the probability of recovery. Exacerbation and relapse. Exacerbation is usually, though not always, see below, called deterioration during the current attack, and relapse, a new attack. According to a poorly founded, but fairly common point of view, the deterioration in the first 6 months of remission is considered an exacerbation, and in the subsequent, a relapse. Most often, exacerbations occur in the first months of remission, then their probability decreases markedly. If the residual effects of depression persist by the time of withdrawal of antidepressants, then the probability of exacerbation is higher. Opinions about the frequency of relapses differ due to the fact that the concepts of remission, exacerbation, and relapse are often interpreted differently. Diagnosis of depression. Diagnosis is based on clinical data. Psychological testing. In the case of monopolar depression, the indicators on the depression scale of the Minnesota Multivariate Personality Questionnaire (MMPI) were increased. There is evidence that this correlates with an increased risk of suicide. Typical deviations on the Wechsler scale of adult intelligence (WAIS-R) are a significant excess of the score for verbal skills over the overall score. Patients often refuse to answer the question or say, "I don't know." When performing the Rorschach test, a long latent response time to the presented tables is characteristic, and the number of responses to polychrome tables is reduced. In the thematic apperception test, the answers are short, stereotypical, and mostly descriptive. Laboratory and instrumental studies. In the 80s, great hopes were pinned on the dexamethasone test, which seemed quite simple, specific and sensitive. However, subsequent studies and clinical trial results have not met these expectations. The pathological dexamethasone test can be observed in various somatic, neurological and mental diseases, such as Cushing's syndrome, bulimia nervosa, Alzheimer's disease and alcoholism, as well as in pregnancy. Numerous studies using positron emission tomography, CT and MRI revealed both functional and structural changes in monopolar depression. Differential diagnosis. A. Many somatic diseases are accompanied by symptoms similar to depression and dysthymia. In a study of 755 patients conducted by the Psychiatric Advisory Service of the General Hospital, almost 40% had secondary depression. The most common causes were stroke, Parkinson's disease, lupus arteritis of the brain, and HIV infection. B. The main mental disorders and conditions with which monopolar depression or dysthymia is differentiated are the normal reaction of loss, psychopathy, adaptation disorders, schizoaffective psychosis, depression in schizophrenia, anxiety disorders and somatoform disorders. Treatment. A. Psychotherapy 1. Psychodynamic psychotherapy 2. Non-directive psychotherapy 3. Rational psychotherapy 4. Interpersonal psychotherapy. B. Medical treatment 1. Tricyclic antidepressants 1. Amitriptyline 2. Dizipramine 3. Nortriptyline 4. Imipramine. Psychodynamic psychotherapy. Belloc developed the basic principles of short-term psychodynamic therapy for depression, not caused by psychosis. In practice, such therapy is often quite long. According to Belloc, the 10 most important mental manifestations to be investigated and corrected are self-esteem, punishing superego needs, self-flagellation, feelings of loss, anger and dissatisfaction, frustration in interpersonal relationships, unmet need for addiction, oral needs, narcissism, denial of latent anger, and all interpersonal relationships, including transference. Classical psychoanalysis in severe depression, especially with psychotic manifestations, is not indicated. Two. Non-directive psychotherapy. It is based on the humanistic concepts of Rogers, Maslow, and Pearls. The patient expresses his thoughts and feelings, and the therapist does not impose his interpretations on him, but only helps to understand himself. An important condition for treatment is empathy, the ability of a psychotherapist to put himself in the place of the patient, to look at the world through his eyes and experience his feelings. The focus is on the current situation, not on early experience and not on the subconscious. There are few controlled trials confirming the effectiveness of this method in depression. Three. Rational psychotherapy. Developed by Beck and Ellis, it is aimed at eliminating the irrational ideas often expressed by patients with depression. Guidelines on rational psychotherapy have been created to facilitate comparative studies of its effectiveness and, to a certain extent, allow it to be applied more flexibly and individually. Most studies have confirmed the effectiveness of rational psychotherapy, including behavioral therapy, for depression. Patients who do not receive or receive minimal psychotherapy served as controls. Four. Interpersonal psychotherapy. Developed by Klerman, Weissman et al., it is based on the assumption that depression is significantly dependent on interpersonal relationships. Treatment aims to facilitate these relationships, improve social adaptation and increase communication skills, reduce secrecy and thus give the patient the opportunity to express their thoughts and feelings. Early experience, the subconscious, and self-knowledge are not given much attention. There is a guide to interpersonal psychotherapy. Tricyclic antidepressants. The main side effects of tricyclic antidepressants are sedative, choline blocking, and cardiovascular. The latter include orthostatic hypotension, tachycardia, and cardiac arrhythmias including pirouette ventricular tachycardia due to quinidine-like effects. This action consists in slowing down the AV and intraventricular conduction and conduction along the legs of the Guise beam, lengthening the action potential of myocardial cells, prolongation of the QT interval on the ECG. In this respect, tricyclic antidepressants are similar to class IA antiarrhythmic agents. The neurochemical mechanisms of all these effects have not been sufficiently studied, but some generalizations of experimental and clinical data are possible. 1. In tertiary amines, amitriptyline, imipramine, the sedative and M-holino blocking effects and the ability to cause orthostatic hypotension are more pronounced than in secondary amines, dizipramine, nortriptyline. 2. The sedative effect and weight gain are due to affinity for histamine H1 receptors. 3. There is a moderate correlation between the ability to cause orthostatic hypotension and affinity for alpha-1 adrenoreceptors. 4. Arrhythmogenic effects may correlate with the presence and concentration of hydroxylated metabolites, especially in the elderly. 5. Sexual dysfunction is caused by many factors, but may depend mainly on the serotonergic effects of tricyclic antidepressants. Desbremy. It has the least M-holinoblockereusham and sedative effect. Due to the lack of expression of the latter in the first weeks of treatment, agitation and insomnia are possible, especially in patients with concomitant panic attacks. Due to the weak M-holinoblockereusham effect of dizipramine less than other tricyclic antidepressants, causes dry mouth, constipation, blurred vision, urinary retention. Cardiovascular effects are common for tricyclic antidepressants, tachycardia, orthostatic hypotension, cardiac arrhythmias, but relatively weak, although sharp drops in blood pressure are possible. Dizipramine is not indicated for severe agitation and insomnia. In such cases, it is better to prescribe drugs with a strong sedative effect, especially in the first weeks of treatment. However, there is no convincing data on whether the probability of remission depends on the compliance of the antidepressant with the clinical picture. Even with severe agitation and insomnia, remission occurs as often with dizipramine treatment as with amitriptyline treatment. Application. First, when choosing a tricyclic antidepressant, take into account which drugs of this group the patient took earlier, which of them he considers best, how his family members react to various tricyclic antidepressants. Second, doses. The average dose is 175 to 300 mg per day inside imipramine or an equivalent drug. The dose of imipramine is usually gradually increased to 3.5 mg per kilogram per day. If at lower doses there is no significant improvement or side effects occur. Amitriptyline. M-holinoblockereushi and sedative effect is the greatest of all tricyclic antidepressants. In this respect, it is compared to dizipramine as like at the other pole. There is evidence that doxepine sedative effect is equally pronounced. Amitriptyline often has not only peripheral, but also central. atypical, seasonal, and other forms of depression. Diagnostic criteria for atypical depression: reactive, not autonomous, mood swings, emotional lability. Dysphoria, excessive touchiness, a sharp reaction to criticism. Severe anxiety, parting anxiety, panic attacks. Hysterical traits, dramatization of reactions to disappointments, changes, and losses. Obsessive fears, fatigue, drowsiness, heaviness in the arms and legs. Paradoxical symptoms, deterioration of mood in the second half of the day, increased appetite, eating to calm down, weight gain. Difficulty falling asleep, often combined with hypersomnia. Absence of personality disorders before the onset of the disease. Psychosomatic complaints are hypochondria. And then, conclusion. Depression, from Lat. Deprimo, push, suppress, a mental disorder characterized by a depressive triad, a decrease in mood and loss of the ability to experience joy, anhedonia, thinking disorders, negative judgments, a pessimistic view of what is happening, and so on, motor inhibition. With depression, self-esteem is reduced, there is a loss of interest in life and habitual activities. In some cases, a person suffering from it may begin to abuse alcohol or other psychotropic substances. Thank you for watching me. Please do not forget to follow my YouTube channel.
Finally, if you do not have these symptoms, I wanted to say something that we should add to your life. How to be happy, 25 habits to add to your routine. Yes, it's possible.
Happiness looks different for everyone. For you, maybe it's being at peace with who you are. Or having a secure network of friends who accept you unconditionally. Or the freedom to pursue your deepest dreams. Regardless of your version of true happiness, living a happier, more satisfied life is within reach. A few tweaks to your regular habits can help you get there. Habits matter. If you've ever tried breaking a bad habit, you know all too well how ingrained they are. Well, good habits are deeply ingrained, too. Why not work on making positive habits part of your routine? Here's a look at some daily, monthly, and yearly habits to help kickstart your quest. Just remember that everyone's version of happiness is a little different, and so is their path to achieving it. If some of these habits create added stress or just don't fit your lifestyle, ditch them. With a little time and practice, you'll figure out what does and doesn't work for you. Daily habits. 1. Smile. You tend to smile when you're happy. But it's actually a two-way street. We smile because we're happy, and smiling causes the brain to release dopamine, which makes us happier. That doesn't mean you have to go around with a fake smile plastered on your face all the time. But the next time you find yourself feeling low, crack a smile and see what happens. Or try starting each morning by smiling at yourself in the mirror. 2. Exercise. Exercise isn't just for your body. Regular exercise can help to reduce stress, feelings of anxiety, and symptoms of depression while boosting self-esteem and happiness. Even a small amount of physical activity can make a difference. You don't have to train for a triathlon or scale a cliff, unless that's what makes you happy, of course. The trick is not to overexert. If you suddenly throw yourself into a strenuous routine, you'll probably just end up frustrated and sore. 3. Get plenty of sleep. No matter how much modern society steers us toward less sleep, we know that adequate sleep is a vital trusted source to good health, brain function, and emotional well-being. Most adults need about 7 or 8 hours of sleep every night. If you find yourself fighting the urge to nap during the day or just generally feel like you're in a fog, your body may be telling you it needs more rest. 4. Eat with mood in mind. You already know that food choices have an impact on your overall physical health. But some foods can also affect your state of mind. 5. Be grateful. Simply being grateful can give your mood a big boost, among other benefits. For example, a recent 2-part study found that practicing gratitude can have a significant impact on feelings of hope and happiness. With a little practice, you may even become more aware of all the positive things around you. 6. Give a compliment. Research shows that performing acts of kindness can help you feel more satisfied. Giving a sincere compliment is a quick, easy way to brighten someone's day while giving your own happiness a boost. Catch the person's eye and say it with a smile so they know you mean it. You might be surprised by how good it makes you feel. 7. Breathe deeply. You're tense, your shoulders are tight, and you feel as though you just might lose it. We all know that feeling. Instinct may tell you to take a long, deep breath to calm yourself down. Turns out, that instinct is a good one. According to Harvard Health, deep breathing exercises can help reduce stress. 8. Acknowledge the unhappy moments. A positive attitude is generally a good thing, but bad things happen to everyone. It's just part of life. If you get some bad news, make a mistake, or just feel like you're in a funk, don't try to pretend you're happy. 9. Keep a journal. A journal is a good way to organize your thoughts, analyze your feelings, and make plans. And you don't have to be a literary genius or write volumes to benefit. It can be as simple as jotting down a few thoughts before you go to bed. If putting certain things in writing makes you nervous, you can always shred it when you've finished. It's the process that counts. 10. Face stress head-on. Life is full of stressors, and it's impossible to avoid all of them. For those stressors you can't avoid, remind yourself that everyone has stress, there's no reason to think it's all on you. And chances are, you're stronger than you think you are. Weekly habits. 11. Declutter. Decluttering sounds like a big project, but setting aside just 20 minutes a week can have a big impact. What can you do in 20 minutes? Lots. Set a timer on your phone and take 15 minutes to tidy up a specific area of one room, say, your closet or that out-of-control junk drawer. Put everything in its place and toss or give away any extra clutter that's not serving you anymore. Keep a designated box for giveaways to make things a little easier, and avoid creating more clutter. 12. See friends. Humans are social beings, and having close friends can make us happier. Who do you miss? Reach out to them, make a date to get together, or simply have a long phone chat. In adulthood, it can feel next to impossible to make new friends. But it's not about how many friends you have. It's about having meaningful relationships, even if it's just with 1 or 2 people. 13. Plan your week. Feel like you're flailing about? Try sitting down at the end of every week and making a basic list for the following week. Even if you don't stick to the plan, blocking out time where you can do laundry, go grocery shopping, or tackle projects at work can help to quiet your mind. You can get a fancy planner, but even a sticky note in your computer or piece of scrap paper in your pocket can do the job. 14. Ditch your phone. Unplug. Really. Turn off all the electronics and put those earbuds away for at least 1 hour once a week. They'll still be there for you later. If you still want them, that is. If you haven't unplugged in a while, you might be surprised at the difference it makes. Let your mind wander free for a change. Read, meditate, take a walk and pay attention to your surroundings. Be sociable, or be alone, just be. Sound too daunting? Try doing a shorter amount of time several times a week. 15. Get into nature. Your green space could be anything from your neighborhood park, your own backyard, or a rooftop garden, anywhere you can appreciate some nature and fresh air. Better yet, add some outdoor exercise into the mix for extra benefit. 16. Explore meditation. There are many methods of meditation to explore. They can involve movement, focus, spirituality, or a combination of all three. Meditation doesn't have to be complicated. It can be as simple as sitting quietly with your own thoughts for 5 minutes. Even the deep breathing exercises mentioned earlier can serve as a form of meditation. 17. Consider therapy. We're certainly happier when we learn how to cope with obstacles. When you're faced with a problem, think about what got you through something similar in the past. Would it work here? What else can you try? If you feel like you're hitting a brick wall, consider speaking with a therapist on a weekly basis. You don't need to have a diagnosed mental health condition or overwhelming crisis to seek therapy. Therapists are trained to help people improve coping skills. Plus, there's no obligation to continue once you start. Even just a few sessions can help you add some new goodies to your emotional toolbox. 18. Find a self-care ritual. It's easy to neglect self-care in a fast-paced world. But your body carries your thoughts, passions, and spirit through this world. Doesn't it deserve a little TLC? Maybe it's unwinding your workweek with a long, hot bath. Or adopting a skin-care routine that makes you feel indulgent. Or simply setting aside a night to put on your softest jammies and watch a movie from start to finish. Monthly habits. 19. Give back. If you find that giving daily compliments provides a needed boost to your mood, considering making a monthly routine of giving back on a larger scale. Maybe that's helping out at a food bank on the third weekend of every month, or offering to watch your friends' kids one night per month. 20. Take yourself out. No one to go out with? Well, what rule says you can't go out alone? Go to your favorite restaurant, take in a movie, or go on that trip you've always dreamed of. Even if you're a social butterfly, spending some deliberate time alone can help you reconnect with the activities that truly make you happy. 21. Create a thought list. You arrive for an appointment with 10 minutes to spare. What do you do with that time? Pick up your cell phone to scroll through social media? Worry about the busy week you have ahead of you? Take control of your thoughts during these brief windows of time. Yearly habits. 22. Take time to reflect. The start of a new year is a good time to stop and take inventory of your life. Set aside some time to catch up with yourself the way you would with an old friend. How are you doing? What have you been up to? Are you happier than you were a year ago? But try to avoid the pitfall of judging yourself too harshly for your answers. You've made it to another year, and that's plenty. If you find that your mood hasn't improved much over the last year, consider making an appointment with your doctor or talking to a therapist. You might be dealing with depression or even an underlying physical condition that's impacting your mood. 23. Reevaluate your goals. People change, so think about where you're heading and consider if that's still where you want to go. There's no shame in changing your game. Let go of any goals that no longer serve you, even if they sound nice on paper. 24. Take care of your body. You hear it all the time, including several times in this article, but your physical and mental health are closely intertwined. As you build habits to improve your happiness, make sure to follow up with routine appointments to take care of your body. 25. Let go of grudges. This is often easier said than done. But you don't have to do it for the other person. Sometimes, offering forgiveness or dropping a grudge is more about self-care than compassion for others. Take stock of your relationships with others. Are you harboring any resentment or ill will towards someone? If so, consider reaching out to them in an effort to bury the hatchet. This doesn't have to be a reconciliation. You may just need to end the relationship and move on. If reaching out isn't an option, try getting your feelings out in a letter. You don't even have to send it to them. Just getting your feelings out of your mind and into the world can be freeing. Eating disorders. Eating disorders, a number of behavioral syndromes associated with eating disorders, anorexia nervosa, bulimia nervosa, psychogenic overeating, psychogenic vomiting, psychogenic swallowing disorder, and some others. It is more common in girls, but young men are also susceptible to this. They can be found in people of all sizes and body types. ED is a psychological disorder, and only some people who suffer from them have experienced extreme weight loss. A person of any weight can feel preoccupied with food, fixated on their appearance and body weight, the desire to torture themselves with physical exertion and strict diets, purify the body through vomiting, compulsively overeat, etc. Weight regain does not mean the restoration of the psyche. Your mind is completely engrossed in a devastating mental disorder, and it's normal not to feel healthy just because your weight has returned to normal. It's not that simple. ED have nothing to do with the fact that you don't love food. ED is a complex disorder involving many factors. This is not a violent dislike of chocolate cake or an aversion to the taste of pasta. Stop devaluing a disease with a 4% mortality rate. The causes of ED that surround us. The media is not the only cause of ED. But because of them, there is a spread of dietary culture, the idealization of unattainable images of the body, the cultivation of an obsession with subtlety, and the idea that a woman is, first of all, the body, and only in the second, the person. Anorexia nervosa. Anorexia nervosa. Eating disorder characterized by deliberate weight loss, in order to lose weight or to prevent weight gain. It is recognized as a type of self-harm. The patient has a distorted perception of their physical form and there is a concern about weight gain, even if this is not actually observed. Statistically, 95% of girls, 5% of young men age from 12 to 30 years, peak incidence of 13 to 14 years and 17 to 19 years. By the end of school, I weighed 72 kilograms at a height of 166. People around me spoke negatively about my appearance. I didn't really care about it, and in the middle of the first year I realized that I needed to lose extra pounds. Phys. The load reached 3 strength exercises and 1 cardio per day, and was weighed several times a day. I felt less hungry every day. The pounds went away quickly, up to about 60, then I excluded meat from my diet. After I was 55 kilograms, I knew that I needed to throw off at least 3 more. I did not want to eat at that time at all. It hurt like crazy. I ate half an apple a day. After that, I decided that I shouldn't eat like this. I went back to 61 and I realized that I am not satisfied with this. I can't look at myself in the mirror. Sometimes I think that I take up too much space on public transport. I drank sunflower oil, I vomited, I lied about food. Because of Phys. First a capillary burst, then a blood clot burst. The hair became brittle. I spent a whole month walking around with a suicide note in my jacket, and the desire to commit suicide does not leave me to this day. About the drugs. Phenibut microcrystalline cellulose furosemide is goodbye to the kidneys, heart and other organs, as honey, don't drink this stuff, as goodbye to life. Bisacidil pain varies from tolerable to such that you want to tear out your entire gastrointestinal tract. Fluoxetine is an antidepressant with a pronounced anorexigenic effect. Rimantadine, goodbye liver. I wanted to lose weight. I was sure that I would lose weight correctly and bought a MCC to reduce the feeling of hunger. It didn't help much. I used to drink laxatives every time I lost my temper. After a while, I found out about flu, and began to take it while sitting on a drinking diet. There wasn't much change, but I was in control. Then I got depressed or something. I was constantly feeling lonely and sad. I thought that everyone hated me, and at some point I started to hate myself. I even cut myself, but it didn't help at all. I wanted to die. At some point, I didn't care. I got tired very quickly and constantly wanted to sleep. I slept a lot. I could go to bed as soon as I arrived from school and sleep until the morning, i.e. from 16 to 5 p.m. to 6 a.m. My muscles were very sore. Sometimes I think, why? Why do I need it? But seeing my weight, I wanted to be less. I don't like my body. I try not to think about it. I take various medications to lose weight, antidepressants, laxatives, cellulose. But in general, lucky, except that the mood is getting worse, and so nothing. Yes, I feel weak sometimes. And so it's fine, it'll do. I began to lose weight in general for the company. There was no specific goal. There are a lot of health problems and heart, and kidneys, and bones, and headaches, but it is unlikely because of drugs asterisk. Judging by the side effects, it is quite possible that because of the drugs. Bulimia nervosa. Bulimia nervosa. Eating disorder characterized by bouts of overeating and excessive preoccupation with controlling body weight, which leads to the adoption of extreme measures designed to reduce the effect of what is eaten on body weight: vomiting, laxatives, strict diets, exhausting training. Statistically, men on average 10 to 15%, morbidity among students 4 to 9%, age range 12 to 35 years, peak 18 years. I didn't even realize that something was going wrong. At one point, I felt very bad, shaken by my friend's suicide. Then, when I noticed myself, I realized that I needed to lose weight. I ran in the morning, did sports, but the result was slow. At some point, my friend said a phrase like 2 fingers in your mouth, it will be easier. I did it everywhere, at home, at school, in a cafe. And yes, I lost weight very quickly, but the weight also quickly returned. There were bouts of overeating, after which I caused vomiting. At some point, my body rejected any food and I was confronted with the fact that I would start eating through a tube. No, I didn't care about the inconvenience. 2,000 kilocalories, that's what I was worried about. I still go on diets, but I can't control my bouts of overeating. I can come home and eat everything in the kitchen in 15 to 20 minutes, but after that, nausea will follow. This is not what I wanted dreaming of thinness. Social media. The largest groups by number. Anorexia, typical anorexia, thinness. Forms of communication, forums, marathons, diaries, photo diaries, answers to questions, reports, support. Causes of ED. Social media reduced self-esteem, loneliness, fear, depression, conflicts in personal life, in the family, difficulties with expressing feelings and emotions, sexual assault, mockery of the forms of the body and the weight of others. The game is not worth the candle? Bulimia always leads to problems with the work of the stomach and intestines. There have been cases of rupture of the walls of the stomach. Food addiction in the form of gluttony and overeating can lead to obesity, heart disease, hypertension, diabetes, etc. Anorexia entails hormonal failure, metabolic disorders, infertility, deterioration of the quality of skin, nails and hair. Self-harm. Self-harm. Self-harm, intentional damage to one's body for internal reasons without suicidal intentions. Self-harm occurs as a symptom of many mental disorders. The most common form of self-harm is skin cuts, scratching of the skin, and there are also blows, burns, pinching of body parts, hindering the healing of wounds, pulling out hair, and the use of toxic substances. I started losing weight. Just started, either from self-hatred, or from the opinions of others. Hunger, drinking diet, rumbling and a wild pain in the stomach became commonplace. My hunger was eating away at me. In a bad mood, the frustrations of loved ones, various diseases. And this is only a small part of the consequences of hunger. Many will say, but why? But no one knows how I came to the fact that the torture of my body began to bring pleasure. Most people don't understand those who hurt themselves. They condemn them, humiliate them. But behind every scar, bruise, and bruise inflicted on yourself, there is a sad story. Self-harm is a way to drown out the heartache, to distract from the problems. Self-harm is the answer. And everyone has their own question. Thank you for watching me. Please do not forget to follow my YouTube channel.